President of Pediatric Association of Nigeria. I want to welcome the PAN President, the NISPID President, PAN Elders, and all PAN members to this third series of the PAN webinar series for the year 2025. Today's episode is very interesting. It's in collaboration with Nigeria Society for Pediatric Infectious Disease to commemorate World Malaria Day. And the title is Intensifying Best Practices in Effective Malaria Case Management, Casting Out Doubt in Practice and Status of Malaria Vaccine Implementation. I will leave the rest to the moderator and the PAN president because we have the masquerade of malaria to demystify it as the presenter for today. So, Madam President, I invite you to welcome, I would invite you to give your welcome address. Thank you, ma'am.
Thank you much, Madam PE. It's very exciting to see a full house. I can see friends from home and abroad in the room already. So the President-elect, PAN Secretary, IPP, Dr. Ogunride, the moderator of the day, and our big speaker, Dr. Lugbenga Mokolu, a professor of pediatrics, President of NISPID, Dr. Regina Uladokun, members of NISPID, partners from Novartis, PAN DPA awardees in the room, PAN elders, esteemed PAN members, good afternoon. It is with great pleasure and a deep sense of purpose that I welcome you all to this timely and important webinar, the third in the 2025 series organized by Pediatric Association of Nigeria in collaboration with the Nigerian Society of Pediatric Infectious Diseases, NISPID, and our valued sponsor, Novartis. Our focus today is intensifying best practices in effective malaria case management, a theme that speaks directly to one of the most pressing challenges in child health across Nigeria and even beyond into the sub-Saharan region. Despite years of effort and significant strides made in malaria control, this disease continues to be a major cause of illness and death among our children. As pediatricians and healthcare providers, we carry the responsibility and indeed the moral imperative to ensure that our case management approaches are evidence-based, up-to-date, and accessible to all children, regardless of geography or socioeconomic status. This webinar offers that vital platform for knowledge sharing and professional reflection. Together, we are here to hear from the big masquerade himself in malaria in Nigeria. We hope we will address existing gaps. We will reinforce strategies that can lead to measurable improvement in malaria diagnosis and treatment outcome. I extend heartfelt appreciation to Novartis for their continued partnership and support for child health initiatives. I also commend the speaker for time spent putting this together, NISPID for facilitating, and every participant that is present here today. Your dedication is the engine that drives progress in child health across our nation. So over to NISPID and the moderator to bring on this much awaited, very important webinar. Thank you very much.
Good afternoon, everyone. Good afternoon, Madam President, the ESCO of PAN, and everyone present. It's our pleasure this afternoon to anchor the webinar on malaria. Malaria can never be oversubscribed. And we send messages to all medical workers, as many cadres as we could, all the way from doctors to nurses to the other general healthcare workers, CHOs, and so on, because everyone has one thing or the other to do with malaria. And as you would have heard, there are people that are still using chloroquine in spite of the national guideline to say don't use monotherapy. People are still using chloroquine. And they say, oh, that's what works for me. It's not just that is what works for you. You need to follow guidelines so that we will not cause problem. But I'm happy that we have, as you have heard, the number one person, biggest masquerade of malaria today to address the issue of malaria and even tell us about what's happening with vaccines as well. But to carry on now, I will just hand over to Dr. Wumi Oyesakin. She's going to moderate for us, introduce the speaker to us. We also have Novartis today. Thank you very much, Novartis. They will give a very brief presentation after the main talk of today. So Dr. Wumi Oyesakin is a consultant in the National Hospital, Abuja, the head of unit of pediatric infectious diseases. She also covers for oncology, and she's a fellow of the National Postgraduate Medical College of Nigeria. So without wasting too much time, because we still have this big lecture we need to listen to today. So I'll hand you over to Dr. Oyesakin. So Dr. Oyesakin, take it over from there. Thank you very much, everyone. Welcome. I see Dr. Olumese all the way from Geneva and a lot of other big masquerades. So, and all of you for coming. Thank you. Welcome. Dr. Oyesakin, over to you.
Thank you, Dr. Oladokun. Good afternoon, everyone. Good afternoon to my teachers and my colleague. I'll just go straight to introduce the speaker of the day. I'm greatly delighted and I want to stand on existing protocol. The speaker of the day is Dr. Olugbenga Ayodeji Makolu, a professor of pediatrics at the University of Ilorin Teaching Hospital in Nigeria, with a focus on neonatology and malaria. He contributed extensively to research on malaria, particularly severe malaria and artemisinin resistance. He had served as a National Malaria Elimination Technical Director of the National Malaria Elimination Program in Nigeria. He was a Portfolio Director of Malaria Project for Management Sciences for Health in Arlington in United States of America. Additionally, he has developed capacity in malaria management and contributed to development of malaria strategic plan documents, which we are using presently, even in Nigeria. He's a mentor to many of us, many fellows in this faculty who have also become professors. It's my delight to welcome this afternoon our great speaker, Dr. Olugbenga Ayodeji Makolu. You're welcome, sir. Please, you have the floor for the lecture. Thank you very much.
Thank you very much. I want to appreciate the opportunity of sharing with us today. I thank Madam President-elect, Madam President Pan, Madam President Nispid, the Madam Coordinator, moderator of today. So I'm the only man in the midst of all these madams, and it's wonderful. Shout out to Professor Taribu. I also see him, and you've also recognized Peter and many other people even joining from the diaspora and locally. I want to appreciate everyone. Our topic of discussion, from the way it sounds, you will know that we're trying not to be too technical. We want to make things simple and to basically address myths and doubts and present as factual and evidence as we can. So I've adopted a presentation mode that provides a bit of scientific information. We deal with the myths or doubts, and then we try to address them as much as possible, trusting that after this session, we will practice our malaria case management with absolute confidence. I will now go to the full screen mode. So I'll be talking to us about intensifying best practices for effective malaria case management, casting out doubts in practice and status of malaria vaccine implementation. So, well, just for some background, globally, the World Malaria Report 2024 reports that we have about 263 million cases of malaria, representing an additional 11 million cases over that of the previous year, and giving us currently a malaria incidence of 60.4 cases per thousand. And the WHO African region continues to carry the heaviest burden, responsible for about 94% of cases, with about 597,000 deaths, which is some improvement from the previous 608,000 deaths, following the rebasing of how malaria mortality is estimated. Nigeria, unfortunately, is responsible for about a quarter of the cases, the blue segment of this chart, as well as about a third, 31% of the deaths. So in specific terms, what that translates into is that Nigeria has about 68 million clinical cases annually, about 190,000 deaths, and still responsible for a third of hospital admissions and two-thirds of outpatient attendance. Various tools are deployed, which I will not be bothering us too much: vector control, chemo prevention, diagnostics, treatment, surveillance, monitoring. And all of these tools, with their deployment, has given us various degrees of success over the last few years. Now, talking about quality of care in malaria case management, what does that refer to? Basically, this is the extent to which health services for individuals with suspected or confirmed malaria increase the likelihood of achieving desired health outcomes and are consistent with current professional knowledge and standards. And wherever we practice good quality of care, it will reduce malaria morbidity and mortality. So key elements in talking about quality of care include prompt and accurate diagnosis, using the relevant tools. We will be going through them. Effective anti-malaria treatment, both for the uncomplicated stage as well as the severe stage. Patient-centered care, respect and responsive services tailored towards patient needs and values, with clear communications. Timeliness is very crucial in malaria. If it was a situation where I had the opportunity, I'll have practically narrated a personal experience with my daughter on the issue of timeliness. Continuity and follow-up. This is very important, as you will see us talk about this. Then health system readiness, availability of trained personnel, diagnostics, medication, all these constitute the dimensions of quality of care. So quality of care is really a broad spectrum issue, dealing with all the practices and infrastructure that support the appropriate care of a condition so that it can grant you the desired outcome. And above all, of course, safety is a key component of this. So what I'll be doing is to take these best practices, highlight some of the myths so that we can hit the nail on the head for issues that people say quite often as we'll interact. So the first myth is this type of general statement: nothing is working regarding malaria control efforts. You hear things like that, your malaria, is it even improving? And you hear it at the highest level. You hear it from leaders, political office holders, and they confront you with that. Sometimes even when they have granted us audience, the first thing they confront us with is this malaria thing working? Okay, so I want to paint a scenario, a picture in our mind to appreciate the progression that has taken place. We need to appreciate that we are not where we used to be, even if we are seeing a few things still happening. For example, in terms of trends in malaria prevalence, you can see what we are having from the data, where in 2010 we used to have a prevalence of 42. In 2015, this prevalence came down to 27%. In 2018, it was 23%. In 2021, 22%. Yeah, you might see that the slope is getting less, all right? It's not as steep as it was before, but then we are still making some progress, as I'll also be relating to us issues around cases averted. Okay, and then you can see also urban-rural divides, but overall, everybody is making that gentle progression. When we look at it again across all the geopolitical zones in the country, we can see also that over time, malaria prevalence is on the average reducing. In Southeast, we have some issues there, as you can see. And then in Southwest, after a dramatic reduction, we're at a point where things appear fairly stagnant. And again, we're seeing a consistent pattern according to the wealth quintile that the person belongs to, as malaria remains, it continues to be different from year to year, but according to all the wealth quintile, you'll see that there's also making of progress, with probably the highest reductions in the highest people of the highest wealth quintile, which is easily explainable. Now, over the years, you can see here that we've had significant contributions that are, remarkable achievements in terms of cases averted. There are ways of estimating this. This is just the Nigerian data. I focused significantly on Nigeria because it's a NISPID PAN presentation. And then you have 228 million cases averted over a 2-decade period, and about 2.6 million deaths averted as a proportion of the fraction of global cases averted. So in as much as Nigeria is in an unenviable position of being responsible for the bulk of cases and the bulk of the deaths, the global trends and the reductions that have occurred over time has also been due to a large contribution from what is being achieved in Nigeria. Now, just have a pictorial orientation towards this map. The very dark components are areas that suggested holoendemicity in the country. And then as it's getting lighter, you can see. So look at the 2000 map, where our typical description there is that malaria is holoendemic in the country, meaning that you have an occurrence, a prevalence that was consistently greater than 75%. But now you see that the portion of the country that has that depth of coloration is reducing. So before, that was almost 90% of the entire country. But now, over time, you can see it representing about 10% in the country and even still getting clearer. So this is just to create an image, putting all the stories of the progress in a dramatic pictorial form for us to appreciate that over the years, we have been making progress. And these same tools that have been deployed in some cases has resulted in improvements and elimination of malaria. Okay. So we now go on into some aspects of the case management. So our best practice number one, according to the guideline, is that all suspected malaria cases should have prompt parasitological confirmatory tests, either with microscopy or malaria rapid diagnostic test before treatment. That is well aligned with the WHO guideline, and that's how our national guidelines also have adopted it. Now, what are some of the myths around this? We have things like an experienced health worker can consistently make a diagnosis of malaria from clinical symptoms. You see that people almost boast of their expertise and ability to recognize malaria clinically. It is a myth. The best of experts cannot tell you it is malaria clinically. We have to test before we can confirm that it is malaria. And in this regard, we need to keep remembering that there are many causes of fever. We don't have all the time to discuss that, but this is just a summary that we could always look with the lens of infections. We can look at reactions to different things. We can look at environmental issues and then some other disorders, connective tissue disorders and all that, that could be causes of fever. So people don't need to get stranded that once fever is negative, it is, if it is not malaria, it is typhoid. And I mean, it happens so rampantly that you'll be wondering whether you are the only one who didn't attend the typhoid class in medical school. So, but if we keep this in mind, we're able to bring to bear alternate considerations that does not make us to just fall into this trap. Now, diagnosis is of importance, as illustrated by this diagram, whereby what happens is in the first cell that says symptom-based diagnosis, where the prevalence of malaria is, let's say, about 40%, then it means that when you are doing symptom-based diagnosis, there's a potential that if you examine 10 people, you might exaggerate the positivity. All right. So we give this illustration that in this type of a scenario, among the people we classified as positive, we're likely to be correct 40% of the time and to be wrong 60% of the time. And then we'll have those that are true negative and those that we might miss as false negative. But if you take that population of those that are positive by clinical symptoms, you now subject them to parasitological testing. This is what this model is trying to explain. You see that among those that were classified falsely as positive, the test helps us to identify them now as true negative. And you can imagine the magnitude of drugs saved, the opportunity for the consideration of other diseases for which we'll have just been treating malaria. Depending on the sensitivity of the tool that we're using for testing, you may have a small fraction that could either be false positive or false negative. But in all of this, we'll have improved our precision in the care of the individual. So this is how testing works. And this is what we need to bear in mind. This is a scenario where if you look at the dotted line is a situation where people started off with empiric treatment, diagnosis of malaria, and calling practically all fever malaria. But when they started testing, malaria cases came down. And you could see until it got to a critical value of where it is in that environment. To lower it from where you are having it will depend on the deployment of other interventions. In my own experience too, we were doing empiric treatment and I thought malaria was occurring all year round. But as we began parasitological testing, I was amazed that where I am practicing actually had seasonal transmission. In the months of January to March, I practice in Kwara. The incidence of malaria approaches zero. And when I was having that, my studies and looking at the trend, I was shocked. I thought it was RDT that was not working. I had called my colleague, Professor Wellington, who does the quality assurance issues. I said, I seem to have problems with my batch of RDT. We were practically zero until we got to April, and then we started becoming positive with the same test kits. And I noticed that cycle over the next 3 years, and it has generally been like that, though our peaks had come down significantly because of several interventions. So this is just to tell us that more often than not, we'll be overdiagnosing malaria whenever we're not testing. Another myth is that RDTs are not reliable. They give so many false negative results. It is not that they are not reliable. It is the fact that we fail to accept that we have that have been built over it doesn't tell you the quantity. So to that extent, it should be understood for what it is. And there are different types, different mix. The first rule in using RDT is to read the instruction of the manufacturer on that particular RDT to know whether it is just an HRP2-based RDT alone. Is it an LDH-based RDT? Is it one that was meant for Vivax alone? We need to first read that instruction. What is the amount of buffer solution that I need to put? And for how long do I need to wait before reading my RDT results? Those are some of the areas of common mistake. Another thing is that wherever you are doing RDT, you should have an extra illumination. It could be a flashlight, it could be a lamp holder, it could be something. Make sure you have an extra illumination because people have missed faint lines, either because of poor illumination or they themselves have parallax issues. They didn't know that they have started requiring glasses and so they won't see those lines. Or sometimes something is blurry and they are misinterpreting that appearance. So there are common errors that could lead to RDT misinterpretation. But you can see from all of this type of illustration that RDTs are easy to interpret. You just need to know exactly what antigen is it made up of. So these are studies in Nigeria, trends in RDT sensitivity. You have variable in this compilation. I didn't have the kind of time to do a further distillation, but largely where you have symptomatic, when somebody has fever and you have symptoms, in such cases, there is a high correlation. Where people are asymptomatic because of the low parasite count, then you tend to have variable results. But here we are talking primarily about those who will come to us with symptoms. They have what we call patent parasitemia, many of those ones, once parasite count begins to get over 1,000 parasites per microliter of blood, the correlation with RDT results is in the order of 90s in terms of sensitivity and specificity. So, but if you're dealing with a population sample in a study that is a mixed bag of different types of people, you can have variable outcomes. So when reading some of these studies, you need to distill and dissect to know what exactly it is. Performance in asymptomatic is different, and that is why we are talking of high sense RDTs in asymptomatic cases and all that. So, but these are data. You see some even have 100%. And then if the comparator for which this sensitivity is calculated is microscopy, the first problem you want to deal with is the competence of the person who is doing that microscopy to be sure that this is a certified level 1 microscopist, or whether it is PCR that they are using in that comparative study. So, but just to show us that over time, so things like the product, variability across region and brand, performance in asymptomatic versus febrile patients, all of these are some of the variables that may explain certain different findings. But overall, you can see that RDTs are high performers. Then a group went further to answer a question. What are the consequences of restricting anti-malaria drugs to rapid diagnostic tests? Supposing I miss somebody because I'm relying absolutely on the test. And the conclusion from this study is what I've cut out for us. This was done by Falade et al. Restricting ACT treatment to MRDT positive febrile children only did not result in significant adverse outcome. So believing in your result did not give rise to people who maybe suddenly died because they were not detected. That's what we're trying to say. And that means that that result is reliable. You are free to exercise doubts. When you exercise doubt and you know the science, you are supposed to do another test, not to discard the test result. You're supposed to do another test. And if two tests with different modes of testing prove negative, then that individual actually does not have malaria. Okay, so this was just to see that to what extent should I have confidence in RDT in our own environment? I know there are several other issues, HRP2 deletion and things like that, but I said my approach in this presentation is to first keep it simple, and then we can discuss other issues. Now, regarding microscopy itself, another myth is that any microscopy is the gold standard for diagnosis. It is not any microscopy, it is expert microscopy. So in our respective setting, you might not know the capabilities of the people that are doing the RDT. We're not saying everybody needs to be expert, but everybody needs to be trained and everybody needs some updates. We have a way of categorizing microscopy. So many people will function well in routine laboratories with as level 3, microscopies. And if you are lucky, you may have some level 2, and then if you are really, really top notch, you will have level 1 certified microscopies. So those ones are there. Even those level 3, if they are properly trained, they can offer the kind of service that is required to back up a routine clinical service. So it's not just any microscopy. You need to be able to deal with that. So in this regard, again, let's remember the basic principles of our microscopy, that it comprises of thick film and thin film. The thick film is for parasite identification, and then the thin film is for speciation. Both of them can be used for parasite density, but you tend to use the thin film for parasite density when there is really heavy parasitemia. As you could see even on this slide, that the red blood cells on the right, all those dots that you are seeing there are actually parasite parasitized red cells. So they tell you that that's a high parasite count, and you can easily do a parasite density with that. We no longer recommend the plus system in estimation. Yeah. So for microscopy, we need to look at the issues. What are the issues for quality assurance for microscopy? One, the scale of the microscopies, the quality of the films that are made, the quality of the microscope. There are some microscopes that have permanent parasites in their eyepiece, so they needed to be taken care of, because if you are not taking care of them and you are dipping them in immersion oil and you are not cleaning those lenses very well, there could be all sorts of artifacts that people will call parasite. Although when people are trained, there is a way by which all that can be sorted out. And then quality of the reagent. So you can see the issues that we need to look at. And then, so we need that the human resource are people trained, qualified, and who go through routine validation. We need maintenance of the microscope and for people to handle it properly. And then slide preparation looks very simple, but significantly technical. And so it has to be made in the right texture, with the right spread, and the right transparency, and of course, the way it is stained. So blood film preparation, how it is read, and the equipment maintenance. So you can see the quality assurance issues that are around microscopy. And you can use this to interrogate your own system, your support system, to find out what is happening. Then you know the kind of confidence that you are putting on the microscopy data that you are getting. So currently, microscopy is supposed to be reported as malaria positive, that is malaria parasite seen, not malaria parasite plus. Okay, malaria parasite seen, clearly stating the stage of the parasite, or when the slide is negative, you say no malaria parasite, so no MP seen. And if it is possible, you add the parasite quantification to the positive cases. So, but all the plus is to be jettisoned. So there are still challenges. I know we've said this. So there is a major gap in the compliance with the 3Ts. There is an increase in RDT use, and there's a lot of room for improvement. We appreciate that. For microscopy, we have challenges with quality assurance, and sometimes in the private laboratory settings, because of different motives of gain, results seems to be read into the intention for gain rather than the reality of what people are saying. Okay, so, and the quality of supervision in several settings, both private, to a large extent, much more private, but to a smaller extent, even in the public sector, for the diagnostic procedure must always continue to be improved so that we all have confidence in the results we are getting. Best practice 2 is treatment, and the recommended treatment is artemisinin-based combination therapies are recommended for treatment for uncomplicated Plasmodium falciparum malaria. So that is the practice, that is the recommendation, and that is the best practice to have. Again, what myths are there? We heard general comments like ACTs are not working, resistance is high. The first problem with that, almost to a very large extent, I don't have the percentages, but if you ask me, I almost put it in 90% of the engagements that I have with people is the diagnosis. Was the diagnosis correct in the first instance? Did they use anything to try and make a diagnosis? Because when I ask questions, you just hear, the person's mouth was bitter, the knee was shaking, and they had lost appetite. So it was clearly malaria. It will not be clearly malaria. Unlike chloroquine, ACTs treat malaria. They are not antipyretics. So they may not give you the rapid relief of fever, but they give you an ultimate early relief of symptoms from malaria. Okay. So all of these are studies that brought about the introduction of ACTs. The natural history of all monotherapies was that resistance developed, but the observations were then made that when combination therapies, the green line at the top, were being used, the um, efficacy was sustained over a much longer period of time. And that observation in year 2001 led to a special consultation by WHO, and the concept of combination therapy was adopted much more formally. And so you no longer treat malaria with with monotherapy. And the recommended anti-malarials are artemether lumefantrine, artesunate amodiaquine, dihydroartemisinin piperacin, and then artesunate pyronarudine. Any of these can be used for treatment of confirmed uncomplicated malaria. So these are the medicines of choice, and they are the ones to be used in the treatment of uncomplicated malaria. I don't have the space to start talking dosage this evening. But still along this regard, because a lot of people talk about resistance, the question is, are these compounds what is the status of anti-malaria resistance in Nigeria? And one is the confusion between the concept of treatment failure and the concept of resistance. In simple terms, treatment failure is when you fail to achieve the objective of treatment, okay, without recourse to start with to the cause. But that reason why you fail to achieve objective of treatment could be the wrong drug, it could be the wrong diagnosis, it could be inadequate dosage, it could be drug-drug interaction, it could be the wrong route of administration. So all of these, whatever they are, that did not allow you to achieve objective of treatment is treatment failure. Of course, inclusive, terminally, is resistance. But in the case of resistance, is a specific situation where there is evidence of adequate therapeutic values of the active component of the drug in the blood and a persistence of malaria parasitemia. Malaria parasitemia could go down temporarily only to have a recrudescence, or it may not even change. Even when the drug is around, the parasite is still looking at the drug in the face. So first, there is a more general loose use of the term resistance than the reality of resistance. So the more common term to first use is treatment failure, which gives us the obligation of rechecking diagnosis, rechecking the dosage, rechecking how it was administered, rechecking whether the person vomited immediately after drug administration. These are all things that can contribute to treatment failure. And that is one of the issues. So many people say things anecdotally that are not supported, but I need you to understand that what we recommend in the country are based on our best available evidence. And when it comes to artemisinin resistance, yes, all of us might have read it has emerged in East Africa and all that. Even what we have now is called artemisinin partial resistance because of the mechanism of action, which means that it remains effective. It might take a slightly longer time in some of those contexts to give you the total cure that you are looking for. But it is not, it hasn't gotten to the level of being useless in the treatment of malaria. So that concept again needs to be understood. So these are some of the countries where it has been reported: Rwanda, Uganda, Eritrea, Tanzania. But here, the question for us in Nigeria is, where are we? So we tried a study earlier on, around 2013, thereabout, and what we did was to just give a monotherapy of artemisinin for 48 hours and then follow it with a full course of ACT. The reason was that we just wanted to see the pure effect of the artemisinin compound. so that we are not checking it against the partner drug to see whether independently it did anything. And we use very stringent method to try and define the sensitivity. And you could see here several of these countries that were in blue. Here we are looking at parasite clearance within 5 hours benchmark, whether you could attain up to about a 50% parasite clearance at that level. And anyone that is going much higher than that was already showing signal of something happening. So here we are in Ilorin, okay, representing Nigeria, and then you have other countries too, and you could see quite a couple of countries. But in Southeast Asia, as of that time, you had started this phenomenon of partial resistance, and you could see that it was taking longer. Okay, this is not the normal duration of parasite clearance. So this is a more stringent condition that was set in order to be able to dictate early signs of failure. What do we do in Nigeria? These are all the tests that we perform annually across the geopolitical zones, just showing us that this is monitored. 2024 was also carried out. So you can see that every year we're doing what is called the therapeutic efficacy studies that are supported by Partners Global Fund and PMI over the years. And even this year will still happen, most likely now coming through World Bank support. So every year we are checking and we are asking the question, the recommendation we have given to people, is it still correct? And so just to show us that this is checked regularly, molecular evaluations are carried out. And you can see that all our ACTs give us the results of parasite clearance. You can see the 3 results, okay, going to 0. But you could see that from day 14, there could be the possibilities of reinfection as or some other forms of treatment. We then subject that to molecular analysis to find out what is called the corrected cure, PCR corrected cure rate. Again, when you start treatment with all ACT, any of the ACTs, you see here that hemoglobin level continue to rise. Okay, it continued to rise. All of them, they restored the value of the hemoglobin when somebody is on treatment. And these are a series of results of the different ACTs tested over time in Nigeria. Other than 2020, which is the COVID year, and we had some serious challenges about that result, you could see that we are having, very high proportions of sensitivity across the board. The figures we have in 2023 about artemether lumefantrine, we had tracked that further in 2024. We are still doing very well. And then you have pyrrolizidine. So look at all the ACTs. They are in the ranges of the definition by which we say a drug can continue to be used. Now, our detailed 2023 result is presented here. You can see corrected cure rate. You can see it now, corrected cure rate across the different states and different study arms. You see it corrected study rate on the whole, 98.6%. So just to show us that our ACTs are proven, they are working. This is corrected with PCR. So to that extent, I want to appeal to us, dear colleagues, that it is not a light matter for us to say there is resistance. We will really need to match up that statement against this level of evidence that exists. And then we try to look for resistant markers. It's not yet reported in the country. We've also done some molecular profiling, trying to do some molecular studies and all of these resistance markers. These are published and we also currently do not have, but we are tracking, we are keeping vigilance, we are watching. But I think there is no cause yet to doubt the efficacy of the ACTs if the diagnosis is correct. So we have guidelines that recommend how to change drugs. with the results over time. Again, we are still within us, we are within this green line, but on the second part, that's where we are. And so we've not seen a reason to change drug. All we have done is to liberalize the use of all the ACTs depending on what is available. But an ACT is the recommended treatment for uncomplicated malaria. There are other special considerations when to give antipyretic, what to do if there is vomiting, how to handle seizures. Then within the neonatal period, again, all I would like to do in this regard is just to recognize the fact that the neonatal period, there could be malaria either because of congenital malaria or neonatally acquired malaria. So this is what I have summarized it to be. Malaria before birth, that's malaria in pregnancy, malaria at birth, that's congenital malaria up to the first day, and then malaria after birth, that's neonatal malaria. It does occur. There is no place for empiric diagnosis. It must be tested because if you miss something like neonatal sepsis, the consequences are severe. But in terms of treatment, recommended treatment of confirmed uncomplicated malaria is still an ACT. And I know there might be questions on dosage and all of that. We'll just take that in their stride. But I want us to know that it can occur. Diagnosis must be pathologically confirmed, and when it does, your treatment is ACT. Please do not use quinine in the newborn wanting to treat malaria. Okay. And then for pregnant women, the recommended treatment for confirmed malaria in the first trimester is artemether lumefantrine. That is evidence-based, that is supported, and WHO has now issued statement on that categorically. In second and third trimester, any of the ACTs can be used depending on local policy, depending on tolerance and all of that, personal tolerance. Yeah, but in first trimester, please, it is not quinine and doxycycline. That has been dropped. It is artemether lumefantrine that is recommended for treatment, not prevention, treatment. But for prevention, it is SP to be commenced at week 13 and given monthly until the last week, last month of delivery. So it's not just 2 doses. We want to give as many doses as possible, but monthly before delivery, before the last week of delivery. We don't want to spare the last month of delivery because of other issues like hyperbilirubinemia and all that. But the more the dosages that the mother is able to get in pregnancy, the better the outcome. And we could avoid issues with folic acid, and then we can administer SP or use low-dose folic acid alongside with the SP. For community management, basically the issue here is we want to train community-level people to recognize severe malaria, give what is called pre-referral malaria, and then refer to the next level. So that is what we do there. Now, for best practice 3, which is severe malaria, here severe malaria remains an emergency. So we have our steps, rapid evaluation, and then correct life-threatening complications and treat with specific anti-malaria. The specific anti-malaria for severe malaria is intravenous artesunate. That's the recommended, okay? And then after you've initiated treatment with that, you follow up with ACT when the person can tolerate orally. So what myths are there? Artemether, which is EMA, and quinine are equivalent to injection artesunate. Artemether and quinine are other drugs you can use, but they are not co-equivalent to the effect of injection artesunate. Artemether, EMA, has no place. in the treatment of severe malaria. It is no longer used. It was a first generation artemisinin compound, and these are now several generations down the line. So please, no matter how it is marketed, there is no place for the use of Ate-Ita, EMA, in the treatment of severe malaria. So I've stated this. These are some of the actions we take for severe malaria. The dosage for artesunate in children less than 20 kg, again, not age. The issue is weight dependent. So the specific criteria here is weight less than 20 kg. Artesunate 3 milligram per kg is given on admission time, that's time 0, time 12, and 24 hours. And thereafter continued daily until the patient can take orally. And when the patient can take orally, you switch to ACT and still give 3 full days of ACT without subtracting it from the duration of injectable artesunate. Ditto the adult, except that the people weighing more than 20 kg, except that the dosage is 2.4 milligram per kg. So where artesunate for now a genuine reason, not from preference of cost, trying to save cost and opting for an alternative, anything less than it in terms of practice and policy of an organization will be bad practice. But you just find yourself somewhere suddenly and you don't have artesunate, and maybe these other ones are available. So fine, you use artemether or quinine at stated doses. The important thing is once you initiate artemether, injection artesunate or any of these injections, you must give it for 24 hours, irrespective of the subsequent improvement of the patient. Okay, so you cannot therefore create a scenario where you give an injection start and say patient should go home. No. If there is a compelling reason that there is a severe malaria-like symptom and you initiate an injectable artesunate, you must give it for 24 hours before you switch on to the oral. So this is very important. And if we recognize this, it means that there will be no space to say, I give this injection start, then I follow up with oral tablets. No. If we ever have to use an injectable, then you must give the first 24-hour dosing. Now, what are some of the evidence? Again, we don't need to belabor this. We all remember this set of studies, Sequamat, Aquamat, Artemether comparison that showed there was a significant reduction in mortality when quinine was considered with artesunate. You see 34.7% relative mortality reduction. Quinine versus artesunate, 22.5% relative reduction. And artemether versus artesunate was a 46.0% relative reduction. So please, we want to appeal to everyone. These drugs are not quite in the same order. Injection artesunate rises far above all the others, and they must be the priority drug for somebody with severe malaria who is already in danger of death. So you give your best to that person who is almost dying to optimize the chances of survival. So these evidences are strong. These are very large data set, over 2,500, so even the last column, the study had to be discontinued. So you can see the first one, 1,400 patients, the Aquaman, 5,425 children, and then this other one was discontinued, 370 adults. Okay, so the options for pre-referral is rectal artesunate in those that are less than 6 years, or injection artesunate, or artemether, or quinine, in that order of declining preference. And then in adults, there is no, for children greater than 6 years, we do not use rectal artesunate. We give the other possible injectables in that order of selection. What's the evidence saying in our country? Severe malaria is something that is occurring almost toe to toe between children under 5 and children greater than 5. That is a major switch from what we were having before, that was exclusively for children under 5. Now, what is happening here is more of a reduction in under 5 than an increase in those above 5. I hope you get me, because a lot of interventions have been carried out among children under 5. And I think we are getting some results there. And that is a fair neglect of people above 5. So it's not as if it's increasing in both sides. I think it's more because it's reducing in under 5. So proportionately, like Avogadro's law, we are having increase in children above 5. The major manifestations are generalized weakness, multiple convulsions, severe anemia, and unconsciousness. And then the diagnostic technique in our study across Nigeria showed that everybody uses RDT predominantly, but in Northeast, Northwest, you see a significant use of microscopy. And paradoxically, in South, there is an unusual level of use of molecular diagnosis. So we hope that that was properly understood and well interpreted. In terms of the prevalence of IV artesunate use, again, it is gratifying to see very high level of IV artesunate. I want you to take note of South. You will notice there that there is a high level of artemeter use and the lowest use of IV artesunate. Just look at that in respect of the next. So kindly put your eyes on South. Look at the amount of artesunate that they are using. They are using other products, and look at the next slide that will show you. Again, so look at it in terms of the death that has occurred and survival rate. The lowest value of this outcome is, you could see that it's in South. All right, so it's South. And yet they are the ones who are using artesunate the least. So I think this is important. This is a national survey across all tertiary institutions. 50 tertiary and high volume secondary institutions in the country. Every state was represented, and you could see that. So it's important to see that case fatality is generally low, but significantly higher in the South compared to the others. So best practice for chemo prevention, we are approaching the end. So this has to do with preventive strategies. I may not be able to explain them, but the various recommended preventive strategies are intermittent preventive treatment of pregnant women, IPTP, sulfadoxine pyrimethamine, which I just mentioned. We have perennial malaria chemo prevention, it's an upgrade of what used to be intermittent preventive treatment in infancy, but this now is spreads to children under 2 years. Then we have seasonal malaria chemo prevention, which we are doing in a big way in Nigeria. It involves 21 northern states, that has rainfall pattern whereby 60% of the rainfall occurs in a cluster of about 4 months. And through the collaboration of everybody, we are reaching almost 29 million under 5 children through this intervention. And then we have intermittent preventive treatment of school children, IPTSC. A randomized clinical trial is going on with respect to that for us to see whether we can make it a national policy. We've already done a prevalence study to try and understand the burden of malaria among school children. Then we have chemoprophylaxis limited to non-immune visitors and children with sickle cell anemia. Then we have malaria vaccine. So very briefly on malaria vaccine, there are 3 types or 3 stages of action of malaria vaccine. The ones that act at the hepatic level, so they are the pre-erythrocytic stage, and they are called the anti-infection vaccine. Incidentally, the current two vaccines that are licensed, RTSS vaccine and R21 vaccine, that looks at the parasite sporozoid, vaccines at that level. Then we have the blood stage vaccines, and those ones are merozoid antigens, and the very advanced candidate in that regard is marriage 5, which we are looking at see whether that can come on board maybe in another 2 to see what happens when you begin to talk about combination of vaccines. And then we have the transmission blocking vaccines as the third category. Look extremely promising, but much more difficult to achieve. So that's about the mechanism of action of vaccines. So where are we in the country? In December, the country rolled out vaccine in 2 states, Kebbi State and Bayelsa State. We had 1 million doses, and when it was calculated in terms of eligible children, Kebbi has the highest prevalence in the country, so it was prioritized. And for equity and justice, North-South, seasonal transmission, stable transmission, we had to look for a state in the South that will make up the balance of what Kebbi we use, so that we can dedicate the available 1 million doses to states. So if we just scattered it across the country, it will be too little and of no effect, and tracking will be a problem. So that's why we just selected those 2 states based on those parameters. And then when other vaccines come, we now know that we are moving entirely to other states. And vaccines are for children under 5 for now, with the entry age as under 11 months. So where the first dose is given at 5 months, then 6 months, 7 months, and then 12 to 15 months for the 4th booster dose. But because we are doing a catch-up, since we're just introducing, the eligible age for entry into this vaccine rollout was set at 11 months. So even if we catch you at 11 months, we will start your dose 1 from that age. Okay. But what has happened? So total dose that was administered, you can see 90,000 for malaria vaccine 1, and then 39,000 for malaria vaccine 2, and then currently 18,000 for malaria vaccine 3. When you break it down, the major challenge we are having is that you can see a rapid drop in the doses of the vaccine. So from vaccine 1 to 2, already we had a 55% drop, and in Kebbi, and then from those 2 to 3, we had a 58% drop. For Bayelsa, the drop is 29% between 1 and 2, and 44% between 2 and 3. So this is something that has been concerning to the government, to the MPCD and Malaria, and in recent times they have been discussing these issues. There are a number of factors that have been identified as being responsible for this. Okay, so it's been taken primary figure to see where we had been and the challenge that we have had. So these challenges are concerning, as I said. So 74%, 76% drop from dose 1 to 2 in Kebbi, 64, then you have 55. And then for Bayelsa, you also have that. So these factors have been analyzed, and mitigating measures are being put in place. So as we implement, we continue to support states, we continue to monitor and evaluate, refine and improve, such that we can achieve 84 to 75% of children reached with malaria vaccine in 2025. So it's a continuous process. You appraise, you correct, and you try to move on. On this note, I want to say that effective case management is critical to our efforts towards malaria elimination. Let us engage in the standard practice of test, treat, and track. By tracking, I haven't talked about it so much because I wanted to concentrate on the case management itself. Tracking means documenting. And if you have tested, then your diagnosis will be recorded and we'll have a true reflection of malaria. But if we keep using suspected diagnosis, our health records will not be useful, it will not be informative, it's not going to show changes over time, and it will just be frustration for everybody. Current recommendations are evidence-based. Let us comply with confidence to the recommended best practices in order to improve malaria outcomes. I thank you very much for your attention.
Prof, for this lucid lecture. We are so well, better informed following this expository delivery. I wouldn't want to waste much time talking so much because Prof has said so much on this treatment and vaccine in malaria. And I just want to list out the myths that he talked about. The fact that people believe that there's nothing working as far as malaria treatment is concerned, and the fact that people felt that any microscopy is the gold standard, and that any clinician can diagnose malaria based on clinical pictures, and the fact that ACT are not working, and the fact that quinine is equivalent to IV artesunate. And all these myths, Prof had, clearly stated the reason why such should not be taken into consideration in our knowledge of the management of malaria. Now we'll go to questions and answers from the chat box. I will hand over to Dr. Ladokun to please handle the questions and the answer session. Thank you, ma'am. Thank you so much, sir. You are greatly appreciated. Thank you so much, sir.
Sorry, Dr. Ladokun.
Thank you so much, Professor Mokolu. We'll just take the Q&A after the Novartis presentation. We have Emmanuel from Novartis. Just to make a brief.
Sorry, Dr. Ladokun.
Oh, yes, sir. Yes, sir.
Can I register that if it is possible, we should not have somebody like Peter on board? I'm not hearing for 5 minutes. Peter is the head at WHO Global Malaria Partnership that is responsible for. So
all right, let him just say hello to us. And I've even seen that he's already answering some of the questions for us. Thank you so much. Please, Dr. Olumese, 1 minute, please, to talk to us. And then we'll move on to the Novartis presentation. Dr. Olumese, please.
Okay, thank you very much. Can you hear me?
Yes, sir, yes, we can hear you.
Okay, well, thank you. Good evening, good afternoon from here. I want to congratulate PAN and everyone for organizing this very important, I think it's important. Sometimes we assume, oh, ordinary malaria, but yet it's killing a lot of our children. So we really need to prioritize it. And Benga, thank you for that excellent talk. Like you said, I've tried to answer some of the questions, some of them in the chat. But please, malaria is treatable, is preventable, and no one should be dying from malaria at this time. There are lots of questions there about the drugs, quinine, SP. Please, let's try and follow simple guidelines, ACTs, artesunate plus ACT for severe malaria. Diagnosis, let's trust our diagnosis, be it rapid diagnostic test or microscopy. And please, apart from all of this, we are also most of us are in different institutions where people are trained let's pass this on as part of in-service training so that it's not only post-service training and all that we have. So thank you very much, and it has been great being part of this. And I remain part of PANCOF every day, so a pleasure to be part of this. Thank you. Bye. Over.
Okay. Thank you so much. I mean, malaria can never be over-prescribed or under-subscribed. Always. That's why with NISPID, malaria is always a favorite for us to present to you, PAN members and other healthcare workers in Nigeria, because we all need to be on the same page. So let's give Novartis, the company that is supporting this webinar, let's give them 5 minutes. Emmanuel, over to you. And I see Michael is also here, who is the one, Novartis West Africa. You're welcome, Novartis. Over to you.
Thank you so much. And I'm just checking if everybody can see and hear me.
Yes, we can.
Okay, thank you. So also standing on existing protocols, and then also appreciating the able leadership of PAN for allowing us to be part of this forum. I believe this is a sequel to our partnership during the PANCOF in Gombe, where again Prof. Mukolu discussed malaria with us. My task this afternoon is a very, very short conversation I want to have on what Novartis stands for as regards malaria. And I'll take a few minutes to introduce what we call the programs team within Novartis. We have a unit within our organization called the programs team, and programs is concerned mainly with sickle cell and malaria. And as we can appreciate, these diseases, the burden of this disease sits mostly with pediatricians. And so we are happy with this partnership, and we hope that we go a long way, in changing the landscape and helping patients in this regard. So we move on to the conversation, and for us at the Medical Affairs Unit, we are not so concerned about brands and so on. Typically, when we have pharma organizations being part of such forum, you would expect that a certain molecular brand is being pushed, but the Medical Affairs team is charged more with scientific conversations, things to do with health system strengthening and so on and so forth. And so we are hopeful that we'll partner with PAN, in moving ahead with some of the initiatives and partnerships that help patients in the long term. As I said, my presentation is a very short one, maybe less than 5 minutes, just touching on the key unmet needs, medically speaking, that remains unclosed. That Novartis stands to work with you as experts in the space, managing patients that you can, work together at. And as Prof mentioned, malaria is still with us, though we have made some significant progress in terms of reducing the burden. It is still with us. And one of the gaps that you identify is mainly with young infants. We identified that there's fewer data that characterizes malaria in this population. And even with the available studies, it's all over the place in the sense that it is not consistent in describing what happens to the young infant who has uncomplicated malaria. And therefore, maybe we have also not looked so much into tailor-made solutions for patients in this category. The other understanding we have, and having talked to quite a number of pediatricians, is the fact that we understand that there's some transfer of immunity from the mother to the child, particularly within the first 3 to 6 months of life. And so we are aware of a certain low index of suspicion when a child has, or particularly an infant, a young infant, has a febrile condition. I understand that malaria tends to be one of the last things to be considered as a possible diagnosis. In fact, one clinician said that she saw while being trained that if you had malaria as part of your differentials when you're managing a febrile case like that, you are likely to repeat your rotation at the pediatrics unit. And I say all this to say that there's some amount of low index of suspicion in this patient. And so when we miss the diagnosis in this patient type, and I'm always awestruck when I talk to pediatricians how they are able to manage patients, some of whom cannot even express things themselves. So just by observation and maybe the report from the caregiver, you're able to understand what is happening and diagnose. It is awesome, but also pose some challenge as regards diagnosis of malaria, even in this patient type. And so the core, as Prof mentioned, is that we should stick to the test, treat, track approach. And as much as possible, when we have any inkling of suspicion, we should test and confirm that there's malaria in there for our next actions. The other challenge that comes about, particularly in this patient type, is the fact that the expression of symptoms of malaria is not so consistent. In fact, the understanding we have is that because they have not fully developed their fully developed immune systems, sometimes or mostly the symptoms that we see in malaria is as a result of immune response mounted. And so, in fact, all that you see about a patient who has malaria may not be even the fever itself, but just um, loss of appetite or refusal to breastfeed and so on. And so it takes a bit of tact, and it also poses a bit of challenge as regards to diagnosis with these patient types. As I mentioned, the symptoms are not specific, and it is easily confused with other conditions that also present with fever and so on. And patients in this category are likely also to have low parasitemia. And so even in terms of the diagnostic tools, it could also pose a challenge as regards diagnosis as well. And when you have gone through all the challenge of diagnosing and we have actually confirmed malaria in there, do we have tailor-made treatment for these individuals, particularly those under 5 kilograms? Of course, the WHO recommends that we use the available ACTs at the same dose per kilogram body weight as for those above 5 kilograms. What for me, I've always asked about, or it intrigues me to find out, is that so if you had, say, a 4-kilogram baby having acute uncomplicated malaria, and then you have to use a dispersible tablet, which is 2120 for those above between 5 kilograms and 15 kilograms. What do you do? Do you disperse the tablets in 5 ml of water and then dispense only for? How do you give the 80% of the dose? So all these challenges, also arise when you want to have a tailor-made treatment for this category of patients. And then again, because we don't have a lot of data in these patient types, what happens, what the drug is doing to the child in terms of the pharmacodynamics, and then what the body of the child is also doing to the drug in terms of the pharmacokinetics is not fully understood. And so, yes, there's a recommendation to do something, but we also agree that there's a lot of data that we can work together, to bring about that helps us understand what happens with the patient better. I recall during PANCOV, Prof, if I recall well, Prof made a certain charge that there are a lot of research topics that can be developed around this segment of patients that I believe going forward, Novartis stands ready to work with you in understanding better what happens with these patients. So, as I mentioned, my conversation is brief and it's just to underscore some of the existing challenges with care for malaria in young infants. And I conclude by saying that there is a risk of malaria in these individuals, and we need to have that appropriate level of suspicion when we do get the patients, and then test before we do anything else. And then, as I mentioned, Novartis is working with you to come up with solutions that is tailor-made, so we're able to close the loop around the unmet needs in this particular patient segment. And so with that, I end the conversation and then still indicate Novartis' readiness to work with you in reducing the scourge of this disease, particularly for the community that we serve, which is pediatric patients. And on that, I end my conversation. Thank you for the opportunity.
Okay, thank you very much, the Novartis group. We must end in the next 5 minutes or so. And watch out the space for Novartis because they have something coming in a couple of months. But it's theirs to reveal what it is. But there's more to come, especially for the young infant. Let me just go to some of the questions that I've jotted down. There are lots, but I'm happy that a lot of them have been dispelled. People who are still talking about quinine or who are talking about some other issues of resistance, those myths have been burst and dispersed by Professor Mokolu. So Professor Mokolu, please, can you take down some of these questions and you just answer them together? So what dose of ACT do we use for extreme low birth weight neonates with malaria? And then there's also the use of parenteral anti-malarial in neonates. Do we use parenteral anti-malarial in neonates? Then the second issue is use of artesunate amodiaquine and the side effect which many have reported, which is lethargy, making the patient more ill. What do you think about this? Please tell us the age recommendation for malaria vaccine again. We know that you have said 11 months and below to catch up, but when we go to the routine immunization, what are the ages again? And then are there training opportunities for malaria microscopy and malaria in general for healthcare workers, especially doctors? So I'll just end the questions there. There are a few more, but I know that please go back to the PAN website later, find the recording and listen again. Many more things would even be clearer. Please fill the feedback form as well. Over to you, Professor Mokolu, to answer some of these issues. Thank you, sir.
Okay, thank you very much. So I've been answering this question on dosage for quite a while. Let me, I'll refer that to Peter. I'll still answer it if he's not here. But let me just say a few things on ASAQ, age with for vaccine and then training opportunities. So artesunate amodiaquine at the current combination and recommended dosage is well tolerated. When it first came out, there was some, the amodiaquine was at a slightly higher dose, and there was significant extrapyramidal effects that occurred, although quite limited really in children. But then the opinion and the experiences of adults dominated, and work was done to reduce the dose of the amodiaquine without compromising its efficacy. So as currently constituted dispersible tablets or what have you that are being used in the children, we no longer see so much of these reactions. The only problem that is occurring on the field is that somehow that notion spread so significantly, and because it is the most European sounding name of all the ACTs that we use, there are natural resistance to people wanting to use it. But once you divorce yourself from those notions, you give it appropriately when indicated to children, you find out that they do very well. And interestingly, whereas all the ACTs have non-inferiority in terms of efficacy, if we were just to be looking at the numbers, by some consistency and sheer coincidence, hardly will you find it having the lowest number when you compare all of them. So what I'm saying is, even if all of them are reporting 96, 97, 98, it's unlikely that you will find artesunate amodiaquine being the one that will be 96. In that bracket, you generally tend to find it being either top or the next one within that. So it remains quite efficacious, it's well tolerated. The dose of the amodiaquine has been adjusted and building upon the synergy of the combination versus when you were just using amodiaquine as a monotherapy. And hence, it is actually quite safe to use, and children tolerate it a great deal. So it's usually the adult carryover opinions that are the issues. Age for vaccine is five months as the point of entry. However, what we are saying is this: we have a sudden quantity of vaccine. We are going to be using it for the first time. All right? In doing that, there must be some element of catch-up that you are going to do to ensure that you still include eligible population as part of this initial rollout. Otherwise, if all that you are waiting for is that the children should be 5 months before they start, then you are going to be on a long wait, and we will not have had the benefit of mass immunization occurring and rapidly generating some measure or level of herd immunity. So for this rollout, therefore, the decision was that anybody that is less than 11 months can start malaria vaccine dose 1 at that 11 months. So we just staggered their own timetable, okay, based on when we start. But we will not be starting afresh for somebody who is older than that 11 months. So what happens today? Somebody who is 5 months, somebody who is 6 months, somebody who is 7, 8, 9, 10, 11, any of these people that come in will get, provided they have not gotten anything before, will get their malaria vaccine dose 1. And then we apply the principle of monthly dosages for the next 3 doses and the booster dose at 12 months. Okay, so that is why you will see us giving a range up to 23 months. It is because we are accommodating where we might be starting with some people. But then as we continue, we'll now be expecting those that are turning 5 months, who are attending regular immunization clinic, to now be the way in which we are servicing and routinizing the malaria vaccine. So, and the studies that were done actually included all of these ages, so it's not as if there is no evidence around it, but this is a catch-up that we are trying to do to bring in as many eligible children as possible. But if they say what is the scheduled timetable for malaria vaccine, it is 5 months of age, 6 months of age, 7 months of age, and then booster at 12 months later. Okay, so what we count is when we start your dose 1. So if we find a 6-month-old, and that is where the person is joining, then that person's dose 1 is given to him or her at 6 months. And then, so it now does 6 months, 7 months, 8 months for dose 1, 2, 3, and the booster 12 months later. If we find you at 10 months, for now that we are doing this, our catch-up, we'll start for you at your 10 months, and then you get your dose 1, dose 2, dose 3 monthly, and then a booster. So that is, by the time we have done those backlog and caught up, then the only population that will be left will be those that are turning 5, in the places where we have started. So every state that we are going for the first time, we'll continue to approach it with that catch-up system. Training opportunities, a lot of training opportunities are bound. There is one program that is called Alamin that is sponsored through a bill and Melinda Gates support to Nigeria and Uganda. Every now and then they put up adverts to support cohorts, although that has to do a lot more with people in malaria program. But again, it is still all these issues we are talking about that are done there. There are case management trainings that are mounted by the program itself. From time to time, we have national trainer of trainers. Pediatricians are mostly involved. By the grace of God, so many people have equally also been trained even through that. Then there is a program called the Science of Malaria Elimination that is even occurring now in Rwanda. So when people say they can apply. Peter, do you want to say something about those in the very low pathway? Just, I had a conversation on that in Pankov, but let them hear again from another neutral person.
Okay, sir.
Yeah,
we'll just have like 1 minute.
Yeah, just 1 minute. I think what I would say, first of all, in those low birth weights on units, we first of all must confirm that it is malaria. You cannot treat presumptively. It may just be sepsis, and even though you find malaria, you may also have other co-infection. But once that is confirmed, then you treat with the ACT, and coartem, artemether lumefantrine can be used. And right now, we recommend that you use the dose that we use for the lowest age group dose for them. I must say that Novartis currently is working on what is called coartem baby, which is a different strength combination of artemether lumefantrine, trying to accommodate for those categories. But currently, until then, you can use the coartem, the one tablet for the less than 5 kg babies. But we must ensure that there is a parasitological confirmation that is malaria. So I think that's all I will say. Thank you.
Thank you very much, sir.
Over to our president-elect. Bye-bye from Nispid.
Thank you very much, Nispid. Thank you very much, Dr. Mokolu, one of my favorite persons, and that's why I couldn't stop him. And thank you very much, Novartis and Dr. Peter from WHO. This has been great. At the height of it, we had almost 200 people attending. And we've heard you reiterate over and over to follow the guidelines. So pediatricians, our elders, our young people, go forth and preach the gospel of following the guidelines. Yes, because if we do that, we will. So I want to thank everybody, esteemed PAN members, for staying all through till now. We'll see you next month for another session of the PAN webinar series. I saw that there's a feedback form. I don't know, I think that's from Novartis. So please, let's kindly put that form in our WhatsApp group so that people can access it and give their feedback on the webinar. Thank you, everyone, and have a pleasant evening.